Welcome to the deep dive. Today we are jumping into a really vital topic in pharmacology, antilipemic drugs. The medications that help us combat high cholesterol and triglycerides, major players in coronary heart disease.
Absolutely. And to really get a handle on these drugs, we first need to understand what we're up against. We're talking about hyperlipidemia, which basically means abnormally high levels of fats or lipids in the blood.
Right, specifically cholesterol and triglycerides.
Exactly. These fats aren't water soluble, so they need transport. They bind to proteins, forming lipoproteins. And it's these lipoproteins that can end up getting into artery walls, kicking off atherosclerosis, that whole fatty streak process.
Okay, so our mission for this deep dive is pretty clear then. We need to unpack the main drug classes, figure out exactly how they work, their mechanisms of action, and crucially, cover the essential nursing process steps for keeping patients safe. Let's get into it. First things first, we need to know the players, lipoproteins. We hear good and bad cholesterol all the time. Can you simplify what these actually are and what they do?
Yeah, definitely. Think of lipoproteins like specialized delivery trucks for fats. They're classified based on their density. There are three main ones you need to know. First up, VLDL, very low density lipoprotein. This truck primarily carries lipids made in the liver out to the rest of the body's cells. Endogenous lipids, basically.
Okay, delivering from the liver outwards.
Right. Then there's LDL low-density lipoprotein. This is the one most people know as bad cholesterol. It's mostly what's left after VLDL makes its deliveries. If you have too much LDL or your body can't clear it efficiently, it builds up in the blood.
And that buildup is the problem for arteries.
That's the core issue, yes. It fuels that plaque formation. And finally, HDL high-density lipoprotein. This is the good one.
The cleanup crew.
Kind of, yeah. It's made in the liver and intestines.
Yeah.
Its main job is reverse cholesterol transport. It picks up excess cholesterol from the tissues and brings it back to the liver to be removed. That's why high HDL levels are seen as protective for the heart.
And the clinical relevance here is pretty stark. The source material highlights that someone with a total cholesterol of 300 mg/dL has, 3 to 4 times the risk of coronary heart disease compared to someone under 200? That's huge.
It really is. And treatment isn't just about hitting a number. It's about prevention, primary prevention before anything happens, and secondary prevention after an event.
So how is the decision made on who needs drug therapy?
Well, it's always in addition to lifestyle changes like diet and exercise. That's key. But the guidelines now really focus on the patient's overall risk profile, things like, age, sex, family history, but also defining major groups. For instance, patients who already have cardiovascular disease or those with really high LDL, like over 190 milli-GDL, they're generally recommended for statin therapy pretty much automatically.
Okay, let's dive into those statins then. HMG-CoA reductase inhibitors, they seem to be the cornerstone, the first-line therapy. How do they actually work on a cellular level?
It's quite, elegant, really. Statins work by inhibiting an enzyme called HMG-CoA reductase. This enzyme is critical. It's the rate-limiting step in the liver's pathway for making cholesterol.
So blocking that enzyme means less cholesterol made inside the liver.
Exactly. The liver then senses this drop in its internal cholesterol supply, and it needs to compensate.
How does it do that?
It increases the number of LDL receptors on its surface. Think of them like docking stations for LDL particles floating in the blood. More receptors mean the liver can pull more LDL out of circulation and back into the liver cell.
Ah, so it's a double whammy, less production and more removal from the blood.
Precisely. That's why they're so effective at lowering LDL levels.
Now, about taking them, atorvastatin, simvastatin are common ones. There's a really specific instruction about timing. Usually once daily, in the evening, or at bedtime. Why is that so important?
That ties back to our body's natural rhythms. Cholesterol production isn't constant. It actually peaks during the night when we're fasting and resting. So, by taking the statin in the evening, you ensure the drug concentration is highest right when the liver's cholesterol factory is most active. It maximizes the inhibitory effect. It just makes sense physiologically. You see therapeutic effects usually within about 6 to 8 weeks.
Got it. Now, we absolutely have to talk about safety. The big one with statins is myopathy, muscle problems, which can escalate to something really serious. Rhabdomyolysis.
Yes, this is absolutely critical for patient education. Rhabdomyolysis is a rapid breakdown of muscle tissue. This releases a protein called myoglobin into the bloodstream.
And that's bad for the kidneys.
Very bad. The myoglobin gets filtered by the kidneys and can cause severe damage, potentially leading to acute renal failure. It's called myoglobinuria when it shows up in the urine.
So what signs should patients be watching for?
They must know to report any unexplained muscle soreness, tenderness, or weakness immediately. And crucially, any change in urine color, sometimes described as tea-colored or reddish-brown. That's a major warning sign.
Early detection is key then.
Absolutely. If it's caught early and the statin is stopped, it's usually reversible. But delayed diagnosis can be catastrophic.
And there are things that increase this risk, right? Interactions. You mentioned statins use the CYP3A4 enzyme pathway.
That's right. So any drug that inhibits CYP3A4 can cause statin levels to rise, increasing the risk of toxicity, including myopathy. Common examples are certain antibiotics like erythromycin or igolon antifungal drugs.
And the famous grapefruit juice interaction.
Yes. Grapefruit juice contains compounds that actually inactivate the CYP3A4 enzyme in the gut wall. This prevents the statin from being metabolized properly on its first pass through the liver, leading to much higher levels in the bloodstream.
So patients should avoid it completely.
The usual advice is to limit consumption significantly. The source suggests less than a quart per day, but many clinicians advise avoiding it altogether while on statins just to be safe. And we also have to mention simvastatin specifically.
Ah, yes, the dose restriction.
Right. The FDA put a limit on the highest dose, 80 milligrams. It shouldn't be started in new patients due to the increased myopathy risk. It's generally only continued if someone's been taking it for over 12 months without any muscle issues.
Okay, so statins block production. What if we need a different approach? Let's talk about bile acid sequestrants like cholestyramine. These are second line.
Correct. Their mechanism is totally different. They aren't absorbed systemically. They work entirely within the intestine.
Oh.
They bind to bile acids, which the liver makes from cholesterol to aid digestion. This binding forms a large complex that can't be reabsorbed, so it's excreted in the feces.
So the body loses bile acids.
And the liver needs to make more. To do that, it pulls cholesterol from the blood, effectively lowering LDL levels. It's an indirect mechanism.
But if it binds stuff in the gut,
Yeah.
that sounds like it could cause problems with other medications.
Oh, it absolutely does. This is a huge clinical point and a major challenge for patients. Because sequestrants bind things nonspecifically, they can prevent the absorption of many other drugs, digoxin, warfarin, even fat-soluble vitamins over the long term.
So how do you manage that?
There's a strict rule. All other medications must be taken either 1 hour before or 4 to 6 hours after the bile acid sequestrant dose. Sticking to that schedule can be really tough.
Wow, that's a significant timing challenge. And what about actually taking the drug itself? I remember reading it's often a powder.
It is, and preparing it correctly is vital for safety and, frankly, for tolerability. It has to be mixed thoroughly with plenty of liquid or wet food, think 4 to 6 ounces. Let it dissolve for at least a minute.
And never take it dry.
Never. It's a serious choking hazard if taken dry. Also, a quick note, cholestyramine contains aspartame, so it's a no-go for patients with phenylketonuria, PKU.
Good point. Okay, moving on. What about niacin? That's a vitamin B3, right? Seems simple but effective.
It is effective and it's inexpensive, which is a plus. Niacin works in a few ways, mainly by inhibiting lipolysis, the breakdown of fat in adipose tissue. This reduces the transport of fats to the liver and ultimately lowers VLDL and LDL while also boosting HDL.
Sounds good, but there's usually a catch.
There is. The main issue with niacin is a very common and often intense side effect. Cutaneous flushing, itching too, pruritus. It feels like a really bad sunburn for some people.
Why does that happen? And more importantly, can you do anything about it?
It's thought to be caused by the release of prostaglandins. The way to manage it is, well, twofold. First, taking a small dose of aspirin or another NSAID about 30 minutes before the niacin dose can help block that prostaglandin effect.
Okay, pre-treatment.
Exactly. And second, taking the niacin dose with meals can help minimize both the flushing and potential GI upset. But even with these strategies, that flushing can be so uncomfortable that many patients just can't tolerate niacin long term, which limits its use despite its benefits.
Right, adherence is always key. Okay, so we've covered drugs primarily for LDL. What if the main issue is really high triglycerides?
That's where the fibric acid derivatives, or fibrates, come into play. Gemfibrozil and fenofibrate are the main ones. They are particularly good at lowering triglyceride levels, and they also provide a modest HDL boost.
And how do they work?
Their primary mechanism is activating an enzyme called lipoprotein lipase. This enzyme essentially breaks down cholesterol and triglycerides in the blood. So they're often used when triglyceride levels are extremely high, partly to reduce the risk of pancreatitis associated with that.
But I feel like there's another warning coming, particularly with statins.
You're right, this is a big one. Combining fibrates, especially gemfibrozil, with statins significantly increases the risk of myopathy and rhabdomyolysis. That combination is generally avoided or used with extreme caution and monitoring.
So not a go-to combo.
Definitely not. Fibrates can also increase the effects of oral anticoagulants like warfarin, so INR monitoring needs to be very diligent if they're used together.
Good to know. Are there any other major players we should touch on briefly? Newer agents.
Yeah, a couple worth mentioning. There's ezetimibe. It's a cholesterol absorption inhibitor, works right in the small intestine wall to block cholesterol uptake. It's often used as an add-on to statin therapy if LDL goals aren't met.
Simple mechanism.
Relatively, yes. And then there are the PCSK9 inhibitors like alirocumab and evolocumab. These are quite different. They're monoclonal antibodies.
Antibodies is cholesterol drugs. How does that work?
It's pretty clever.
Mm.
PCSK9 is a protein that normally degrades LDL receptors on the liver. By inhibiting PCSK9, these drugs prevent the breakdown of those receptors.
So more receptors stay active on the liver surface for longer.
Exactly. Which means the liver keeps pulling LDL out of the blood very effectively. They can lower LDL by a huge amount, sometimes up to 70%.
Wow. But I imagine there are differences in how they're used.
Big differences. They're not pills. They are given by subcutaneous injection maybe every 2 weeks or once a month. And they are significantly more expensive than statins, so they're typically reserved for patients with genetic high cholesterol conditions or those who truly can't tolerate statins or aren't getting enough reduction with maximum oral therapy.
Okay, we've covered a lot of ground on the drugs themselves. Now let's pivot to how this all applies in practice. The nursing process. How do we ensure patient safety and make sure this therapy actually works?
Right. This is where it all comes together. Assessment is absolutely foundational. You need a really thorough history before starting any of these drugs.
What kind of history?
Well, obviously medical history, other meds, allergies, but specifically family history of high cholesterol or heart disease is important. Alcohol consumption needs to be assessed. And you have to ask about dietary patterns and any supplements or herbals they might be taking. Things like garlic or flaxseed can sometimes affect lipids or interact.
And baseline labs are crucial, I assume.
Oh, absolutely. You need that baseline lipid profile, total cholesterol, LDL, HDL, triglycerides. But just as important, especially for statins, are liver function tests, AST and ALT, and baseline CPK level, which measures a muscle enzyme.
Why the liver enzymes in CPK?
Because statins can cause liver enzyme elevations, although significant liver injury is rare, and the CPK gives you a baseline to compare against if the patient later reports muscle symptoms, helping diagnose myopathy. These labs, particularly liver enzymes and sometimes CPK, are typically monitored periodically, especially in the first 6 months of statin therapy, say, every 6 to 8 weeks initially.
Okay, baseline established. What about implementation, actually giving the drugs and managing the patient day to day?
A few key things. Remember that long-term therapy, especially with bile acid sequestrants that interfere with fat absorption, might require supplementing fat-soluble vitamins, A, D, E, and K.
That's a good point about potential deficiencies.
And managing side effects proactively is huge for adherence. Many of these drugs can cause GI upset, particularly constipation with sequestrants. So encouraging fluids maybe up to 3 liters a day if there are no contraindications like heart failure, and increasing dietary fiber can make a big difference.
And constantly reinforcing those administration rules we talked about.
Absolutely critical. Statins in the evening. That 1 hour before or 4 to 6 hour after rule for sequestrants and all other meds. The aspirin or NSAID trick for niacin flushing taken 30 minutes before. These details matter immensely for effectiveness and safety.
So how do we evaluate if the therapy is working and the patient is safe?
Evaluation has 2 main goals. First, are the lipid levels improving? We monitor the follow-up lab results to see if they're reaching the target goals, like LDL below 100 mg/dL or whatever the specific goal is for that patient's risk level.
And the second goal?
Early detection of adverse effects. Are they having muscle pain, GI issues, any signs of liver problems? This requires ongoing assessment and really listening to the patient.
And this links back directly to adherence, doesn't it? Especially with statins.
It really does. The source material points out a striking statistic. Muscle pain is the reason cited by about 60% of patients who stop taking statins. 60%. That's massive.
So if we don't manage or at least acknowledge and discuss that side effect,
Patients will just stop taking the drug. And stopping therapy significantly increases their long-term cardiovascular risk. This is why patient education isn't just a nice to have, it's probably the single most important tool we have. Clearly explaining the benefits, being honest about potential side effects, explaining how to manage them, and emphasizing why sticking with the therapy is so vital for their health.
that really brings it home. Okay, let's do a quick wrap-up of the main takeaways. We've seen that statins are the workhorses, blocking cholesterol production and boosting its removal. Bile acid sequestrants work in the gut, forcing the liver to use up cholesterol. And fibrates primarily target high triglycerides.
Right. And across the board, patient education on timing, side effect reporting, especially muscle symptoms with statins, and the importance of adherence is paramount.
Definitely. It's clear that understanding these drugs goes beyond just the pharmacology.
It really does. It's about the patient experience. And that leads me to a final thought for you, our listener. We know muscle pain is the biggest barrier to patients staying on statins, drugs that could literally save their lives. So the question to really mull over is this. How can your communication clear, empathetic, repeated communication about why the long-term benefits often outweigh manageable, reversible side effects? How can that fundamentally change a patient's adherence and ultimately their health trajectory? Something to think about.